I want to thank the chairman and ranking member for going down this road. This is, to me, this is an important area. I'm a fresh face around here, just 5-6 weeks, and came actually from a nonprofit community health care, working with a lot of older adults, rehabilitation, and a licensed nursing home administrator. So it's extremely important issue, and I have a couple obviously concerns, and looking forward to. And thank you to the panel too for your testimony and all of your information. It's very much appreciated. My concerns in looking at this whole topic really has to do two things, probably a lot of things, but primarily cost, what it does to cost, and what it does to complexity. Cost in terms of ultimately concerned with what this will do as we reduce competition over time and drive cost up in terms of access and affordability, and complexity in terms of the consumer or older adults. And these are folks who, with medical complexities, will have a real hard time dealing with, having distant suppliers and multiple suppliers and ownership over equipment that they know that they need to use, but they don't understand maybe how it works. Some real issues. And I guess my first question I'd like to throw out to the panel, just in general reaction, to see what your reaction is to those folks like myself who have this concern that because of the implications of this, of what's proposed, of what we're looking at, can really take some of the most at-risk adults who are aging with dignity in their homes and would actually drive them back into institutional settings because of issues related to cost and the complexity. Any thoughts in terms of what risk that we run in that situation?
I'd like to start the conversation, if I may. I think part of the basis of competitive bidding came from the demonstration projects in Polk County and San Antonio. What is a fallacy is that there was a true savings there, because anything that might have caused a patient to go to the emergency room, go to a hospital, because he wasn't receiving care, would be charged to the Medicare Part A budget. And there was absolutely no cross-referencing of spikes in Medicare Part A as opposed to any losses in Medicare Part B. So that's the first issue. I think one thing that we all can say is that when patients don't get care, and many of them depend on our agencies, they don't have family members, they don't have spouses to care for them, they go to the hospital. They go to the emergency room. And again, that is a cost to the Medicare budget, but it's in Part A. And there's never been an analysis of how that cross-references.
Right.
And we would expect that to happen over and over again.
I would say one problem we had in the Miami MSA is patients receive these booklets from Medicare, and I actually had a patient that I've had for some time that the patient called me up and said, well, I don't see you on this list, and so I think I need to get my equipment picked up and try to find another supplier that was listed in their city, and there was no one in their immediate city, and it was very confusing for the patient. We actually had a company that was a bid winner, but they didn't have the DBA name of the company listed was sent out to the patients, and they told them, well, I need to change my supplier, and it became very frustrating for the bid winner, who had to try to explain to the patient, and the patient saying, well, I'm sorry, I've got to work with my doctor and try to get one of these other companies to provide me the service that I need, and that was a real problem. A lot of confusion for the patients, and actually it's still going on from the cleanup that happened in July.
Mr. Thompson, last week in Charlotte we had a very small little snow shower, but it resulted in ice. Mr. Schuler can probably tell you that in North Carolina that just a little bit of snow will shut local communities down. The very fact that we went in the Charlotte CBA from approximately 130 oxygen providers down to 11 oxygen providers under this current competitive bidding scheme should be evidence enough that those 11 providers cannot provide the oxygen support and services if their power had gone out, if there had been ice on the power lines and their power had gone out. You can't deliver oxygen services in that broad of an area by 11 suppliers. I was delivering oxygen during Hurricane Hugo. For about 11 days, I delivered oxygen tanks. And I know some of my colleagues here have delivered oxygen in Florida and different places. You can't do it with the smaller numbers of suppliers. So, yes, the Medicare beneficiary is going to the hospital.
Okay, thank you.
If I could add to that, I don't think we can underestimate the value of what the services provided by the small provider. For many of us in our communities, these are our neighbors, our relatives, our friends. These are not people who are Medicare numbers or beneficiaries. They're very important to us as people. I'm sure I speak for many people in this room when I say when certain clients call into our office, everybody knows and smiles and says, it's Mrs. Smith again. But we rush out and we take care of Mrs. Smith. That's what we do. That's how we've built our business. Under a program like this where price becomes the issue and our product is made more to look like a commodity, our service is ignored completely, I think is missing the whole point of health care, and which is what we are health care providers.
I would echo that sentiment, sir. I believe service is what we provide to our patients. As a physician, the outcome of my patient is important to me. I'm outcome driven. I want everyone to get a good result. That makes it important for me to make sure they get the right device, that it fits them properly, that I'm sure that's going to take care of their problem. Medicare doesn't reimburse me for that. That's okay. I want the best outcome for my patient. Medicare's busy crunching numbers and worried about bidding and cost. We're worried about our patients and the service to our patients, which they really haven't quantified and haven't addressed.
And that certainly inherent value I've seen in mom and pop providers. They care about the people, and they do much that goes above beyond what they're paid for. So